I'm Don Vinh, infectious disease physician and medical mycologist at the McGill University Health Center in Montreal, Canada. I will be discussing prophylaxis in patients with neutropenia. Several studies evaluating the Canada-directed prophylactic efficacy of azoles in patients undergoing intensive cytoreductive therapy for remission induction of AML or high-risk MDS were conducted in the 1990s. In this setting, fluconazole at 400 milligrams once daily compared to placebo demonstrated no significant effect on the incidence of invasive fungal disease, overall mortality, or fungal attributable mortality, but it significantly prevented oropharyngeal candidiasis. When compared to amphotericin B in this setting, fluconazole was as efficacious but better tolerated. Similarly, the combination of fluconazole and itraconazole had similar efficacy to liposomal amphotericin B with fewer adverse events. An important multi-center randomized controlled trial compared fluconazole 400 milligrams once daily to placebo. The study demonstrated a significant reduction in proven invasive candidiasis and in fungal attributable mortality. However, the study population included patients with AML and MDS, as well as those with autologous hematopoietic stem cell transplant, precluding a conclusion of benefit in those with AML and MDS alone. Furthermore, in a post-remission setting, when duration of neutropenia can be shortened by administration of granulocyte colony stimulating factors, the effect of fluconazole prophylaxis may not be beneficial regarding incidence of proven invasive candidiasis and fungal attributable mortality. Itraconazole has similarly been studied as prophylaxis in patients with AML or MDS undergoing intensive cytoreductive chemotherapy. When compared to fluconazole, four sequential meta-analyses demonstrated that while itraconazole is effective as antifungal prophylaxis, it is as effective as fluconazole with no significant difference in overall mortality. Importantly, itraconazole use was associated with a significantly higher risk of adverse events, often requiring its stoppage. In a landmark study assessing the prophylactic efficacy of posaconazole in AML or MDS patients when compared to the institutional standard of care using either fluconazole 400 milligrams daily or itraconazole oral solution 200 milligrams BID, posaconazole was associated with lower rates of probable or proven invasive fungal disease, so 2% versus 8%, lower rates of 100-day mortality, 14% versus 21%, and lower rates of fungal attributable deaths, 2% versus 5%. Most of the beneficial effect was driven by the effect of posaconazole on mold infections, while the incidence of invasive candidiasis in all groups was too low to discern the effect of each regimen. So specifically, the number of cases of invasive candidiasis in the posaconazole group was 3 out of 304 subjects. In the fluconazole group, it was 2 out of 240 subjects. And in the itraconazole group, it was 0 out of 58 subjects. Another RCT comparing posaconazole to fluconazole in AML-MDS patients similarly showed that the former, posaconazole, was associated with a significantly lower incidence of proven or probable IFD, 5.1% versus 14.5%, although the lower all-cause mortality rate was not significantly different, 2.56% with a 95% confidence interval of 0.5 to 7.3 versus 5.98 with a 95% confidence interval of 2.4 to 11.9, respectively. The benefit of posaconazole prophylaxis during induction or salvage chemotherapy may extend beyond this chemotherapy phase with the reduced risk of IFD in patients who then proceed to allogeneic stem cell transplant. In situations where posaconazole cannot be safely used, for example, due to drug interactions or prolongation of the QT interval, isovuconazole has been shown to be a safe and effective alternative prophylaxis agent in this setting. Of note, however, isovuconazole failed to demonstrate non-inferiority when compared to caspofungin in the treatment of patients with established candidemia or invasive candidiasis, most of whom were non-neutropenic. This finding was despite isavuconazole in vitro activity, at least as good as posaconazole or voriconazole, based on MIC 50 and MIC 90 data. The beneficial prophylactic effect of isavuconazole observed in MDS or AML patients may reflect its activity against mold. As such, the committee's recommendations are as follows. Azoles are considered the first choice for primary antifungal prophylaxis for patients undergoing intensive remission induction chemotherapy for AML or MDS. Because of the shift in the pattern of invasive fungal disease in this clinical context, due primarily to increasing rates of filamentous fungi, as well as increasing incidence of non-albicans Candida species that have intrinsic resistance or limited susceptibility to fluconazole, mold-active primary antifungal prophylaxis with posaconazole or other mold-active drugs are recommended in patients rendered long-term neutropenic, that is to say, 7 days or longer, from remission induction chemotherapy for high-risk MDS or AML. In this section, I will be discussing prophylaxis of invasive candidiasis in adult hematopoietic stem cell transplant recipients. Prior to the implementation of antifungal prophylaxis in HSCT recipients, Candida species were the primary etiology of invasive fungal disease in these patients, manifesting primarily as candidemia, which occurred in 10 to 30% of patients with associated mortality rates of 50 to 75%. In 1992, a landmark trial demonstrated the efficacy of fluconazole, 400 milligrams once daily, as prophylaxis in HSCT recipients, initiated at the start of conditioning and given until engraftment, i.e., during the period of neutropenia. Compared to placebo, fluconazole reduced the incidence of superficial disease, so 33% versus 8.4%, and importantly, of systemic disease, 15.8% versus 2.8% during the treatment period. However, no improvement in survival was observed. Another pivotal study in 1995 assessed the efficacy and safety of fluconazole prophylaxis in HSCT recipients, initiated within 24 hours of conditioning, but continued for a longer period, i.e. until day 75 after transplantation, thus spanning both the periods of neutropenia and post-myeloid engraftment. Compared to placebo, fluconazole use was associated with a significantly decreased incidence of colonization, so 86% versus 77%, with a p-value of 0.037. Superficial fungal disease, 7% versus 0%, p-value less than 0.001. Suspected systemic infection, 55 versus 38%, p-value of 0.006. Proven systemic infection, 18% versus 7%, or the p-value of 0.004, and death by day 110 after transplant, 21% versus 19%, but with a p-value of 0.004. In addition to the longer period of fluconazole prophylaxis, this latter study notably included a higher proportion of allogeneic transplants than the former study, so 88% versus 48%, which may have also contributed to the observed effect on mortality early after HSCT. The beneficial effect of fluconazole relative to placebo was shown to extend beyond day 75 post-HSCT with reduced overall incidence of invasive candidiasis, so 2.6% versus 20.3%, with a p-value less than 0.01. Reduced candidiasis-related deaths, 0.8% versus 8.3%, p-value of 0.0068. Decreased severe gut graft versus host disease, 5.5% versus 14%, p-value 0.02, and improved long-term survival of 44.7% versus 27.7%, with a p-value of 0.0001. So these studies established fluconazole prophylaxis in HSCT recipients as the standard of care to prevent invasive fungal disease. Because of the emergence of fluconazole-resistant candidal infections and molds as major causes of peri-transplant morbidity and mortality, studies on antifungal prophylaxis using agents with a broader antifungal spectrum were initiated thereafter. In 2003, an open-label, multi-center randomized trial comparing itraconazole to fluconazole prophylaxis administered within the first 100 days of allogeneic stem cell transplant demonstrated decreased rates of proven fungal infection with itraconazole, so 13% versus 28%, p-value of 0.03, specifically with decreased rates of invasive candidiasis, 9% versus 25%, p-value of 0.01. Although most of the benefit of itraconazole was observed in mold infection, among those cases with proven candidiasis, there were fewer cases in the itraconazole group than in the fluconazole group, particularly when Candida glabrata or Nicoziomyces glabratus and Candida krusei or Pichia kudryavzevii were involved. In 2004, a double-blind trial compared the efficacy and safety of micafungin 50 milligrams once daily to that of fluconazole 400 milligrams once daily for the prevention of invasive fungal disease during the neutropenic pre-engraftment phase of autologous and allogeneic stem cell transplant. Treatment success was defined a priori as the absence of proven, probable, or suspected fungal infection through the end of prophylaxis therapy, as well as the absence of a proven or probable systemic fungal infection through the end of the 4-week post-treatment period. Micafungin demonstrated a higher overall success rate than fluconazole, so 80% versus 73.5%, and both agents were associated with a comparable rate of breakthrough candidiasis, 0.9% versus 0.4%. In a similarly designed study from South Korea, comparing micafungin 50 milligrams once daily to fluconazole 400 milligrams once daily, administered in the pre-engraftment phase among adults receiving allogeneic or autologous transplant, there was no difference between the two antifungals when assessing the incidence of proven or probable IFD up to day 100 after SCT, the incidence of possible, proven, or probable IFD, the need to change antifungals before engraftment, IFD-related mortality, or survival within 100 days of SCT. With respect to breakthrough candidiasis, these events were rare and comparable between the two fungal arms. Now, the factors potentially contributing to the different conclusions of these two similarly designed studies may be related to the inclusion of pediatric patients, so approximately 10% in the former, but 0% in this one, or the proportion of patients with acute leukemia, 14.4% versus 26% respectively, and stem cells as the source of transplant, 68.7% versus 99.2% respectively. In another study not shown in this table, micafungin at a minimum dose of 100 milligrams once daily in 44 allogeneic stem cell transplant patients was compared to historical control patients who had received fluconazole prophylaxis, showing decreased rates of proven, probable, and possible IFD with micafungin, so 12.2% versus 34.5%, p-value 0.038. Focusing on the Candida data, one case of candidemia and one death from disseminated candidiasis were observed in the fluconazole group, while no case was reported in those receiving micafungin. In a prospective randomized trial, again, not shown in this table, that compared micafungin 150 milligrams once daily to fluconazole 400 milligrams once daily during the pre-engraftment phase, micafungin was comparable to fluconazole in the treatment success rates. So we're using similar definitions as previously, with rates of 94% versus 88%, p-value 0.295, and no cases of candidiasis were reported in either arm. Micafungin 50 milligrams once daily has also been compared to itraconazole 5 milligrams per kilogram BID oral solution in adult allogeneic and autologous HSCT recipients during the pre-engraftment phase. Based on the primary endpoint, which was defined a priori as no proven, probable, or suspected IFD through therapy and absence of proven or probable IFD through the end of the 4 weeks after therapy, micafungin was non-inferior to itraconazole, 94.6% versus 92.6%. That p-value was 0.48. Significant differences with respect to better tolerability for micafungin were noted, with lower rates of adverse events, 8% versus 26.5%, and lower rates of study withdrawal, 4.4 versus 21.1%. With respect to the effect of Candida species, colonization with Candida albicans was similar at baseline in both groups, 0.7%. And at the end of prophylaxis, C. albicans was recovered more often in the micafungin-treated group, 5.1% versus 0%. Colonization with the other candidal species was similar between groups. The rates of proven candidiasis were low in both intention to treat populations, with micafungin at 0.7% and itraconazole at 0%. In a phase 4 multi-center non-interventional prospective cohort study in Greece, the real-world experience of micafungin as either prophylaxis or treatment of Candida infection was evaluated. Micafungin was administered as prophylaxis to 74 subjects, of whom 14 had HSCT for hematological malignancy. The remainder had hematological malignancy only, or HSCT for non-hematological malignancy. The overall effectiveness in the entire prophylaxis group was 90.5%. Unfortunately, details on the prophylaxis failure cases were not provided. Voriconazole has been compared to fluconazole as prophylaxis and allogeneic SCT administered until day 100 for standard risk, or day approximately 180 for higher risk, in a structured fungal screening program. And that is to say, with intensive monitoring by clinical and serum galactomannan screening to assess the impact on the incidence rates of IFDs, on fungal-free survival, and on overall survival on day 180 and at 1 year post-SCT. Overall, there was no difference in IFD, fungal-free survival, nor on overall survival between the two fungal agents. Specifically, the rates of candidiasis between fluconazole and voriconazole were comparable at day 180, so 9% versus 13.6%, and at day 365, 7.3 versus 15.8%. Voriconazole has also been compared to itraconazole in allogeneic SCTs, starting on the day of transplant and administered for at least 100 days, or extended to day 180 if risk factors for IFD persisted. The primary composite endpoint, termed success of prophylaxis, was based on the ability to tolerate the study drug for the at least 100 days of treatment period, with less than or equal to 14 days interruption, and survival to day 180 without proven or probable IFD. In this regard, voriconazole was better than itraconazole, 48.7% versus 33.2%, p-value less than 0.01. Only 2 cases of candidemia occurred, and both were in the voriconazole group. In patients who have undergone allogeneic SCT that was complicated by either acute graft versus host disease, so grade 2 to 4, or chronic extensive graft versus host disease, or GVHD requiring intensive immunosuppression, posaconazole was compared to fluconazole under a fixed treatment period of 112 days. In terms of the impact on the incidence of proven or probable IFD, posaconazole was non-inferior to fluconazole, so 5.3% versus 9.0%, p-value of 0.07, with the greatest impact on aspergillosis, while the rates of candidiasis were 1.3% in each. Posaconazole 200 milligrams TID oral suspension was also compared to posaconazole, same dose, but combined with micafungin bridging using 50 to 100 milligrams once daily in SCT recipients who were temporarily unable to take oral medications, for example, due to severe mucositis or nausea, in whom posaconazole exposure was impaired, such as from low plasma concentrations, intestinal GVHD, or severe diarrhea, or who developed adverse events while on posaconazole, such as elevated hepatocellular enzymes or prolonged QT interval. The posaconazole micafungin cohort was compared to a historic posaconazole alone cohort, and prophylaxis in both groups was initiated with conditioning and continued until day 100 after SCT, or longer if GVHD required further immunosuppression developed. The two strategies had comparable rates of breakthrough probable improvement IFD. So 2.8% versus 1.9%, p-value of 1. One case of candidiasis occurred, and it was in the posaconazole micafungin group. Although patients in the posaconazole micafungin group were less likely to have possible IFD, so 16.0% versus 3.8% with a p-value of 0.005, and improved fungal-free survival on day 100 with a p-value of 0.009, no significant differences were observed for persistent febrile neutropenia, duration of hospitalization, or overall mortality. In a retrospective review of hospitalized patients with hematological malignancy in which a microbiologically documented fungemia was diagnosed, candidemia occurred in 32% of HSCT patients. Specific details on this HSCT candidemia cohort were not explicitly provided. Among all 174 patients with candidemia, antifungal prophylaxis was provided to 46%, which is 80 patients. Of these, 36% patients, or 21%, received fluconazole, and 44 patients, 25%, received a mold-active agents. 168 patients, or 96% of patients with candidemia, so essentially all of patients with candidemia, had a central venous catheter. Treatment of candidemia included anakinra in 52%, liposomal amphotericin B in 25%, or fluconazole in 15%, 1-5. Central venous catheter removal following fungemia identification occurred in 83 patients, or 47.7%. Among those with candidemia, death occurred in 66 cases, so 38%, of which 30 were attributable to Candida infection. So overall, the committee's recommendations for the prophylaxis of invasive candidiasis in adult HSCT recipients are as follows. In adult patients undergoing allogeneic SCT for hematologic malignancies, primary antifungal prophylaxis with fluconazole has been shown to provide a survival benefit in the early period following transplant, as well as long-term survival. We therefore strongly recommend fluconazole in adult patients undergoing allogeneic HSCT. Fluconazole remains a standard of care in many centers where it is administered from initiation of the conditioning regimen through engraftment and usually extended to day 75 after HSCT to cover the period of highest risk for the development of acute GVHD. Subsequent trials comparing agents with a broader antifungal spectrum to fluconazole have shown no significant difference in terms of effect on candidiasis, but have occasionally demonstrated a trend towards less breakthrough mold disease and decreased need to use empiric or targeted anti-mold treatment. However, no study was identified showing that mold-active prophylaxis results in improved survival in the early period or long-term following transplant.